Hello, good morning everyone. Today's our seminar is on angiographic assessment of coronary lesions, which will be presented by Dr. Anand SHUKLA sir, who is professor in cardiology and having 20 years of experience. Thank you.
Good morning, myself Dr. Anand SHUKLA. Today I am discussing the coronary angiography lesion assessment on the revascularization point of view. Before start of the angiography, first we have to remember the person who invented the angiography, that is Mason Sons in 30th October 1958. This is the simple angiographic, this is ceiling mounted, this is the image intensifier, this is the X-ray tube. The position of the image intensifier denotes the AP, if it is anterior, left anterior oblique, the LO, right anterior oblique, that is the RO. So denotes the position of the view. So what are the different gantry position to take the angiographic view? If you want to assess the left main ostium, one is the LO caudal, and important is the cranial view, either AP cranial, slightly RO cranial or slightly LO cranial. These are the best view to assess the left main ostia. If you want to assess the left main bifurcation, then the LO caudal and the RO caudal view will be the better option. And a plain AP, dead AP, slightly cranial will be also the good option for the left main bifurcation. If you want to see the LAD proximal, then it is a RO caudal view, that is a best. We can see the LAD proximal segment as well as an LO caudal view also. So best view is the RO caudal and plain RO followed by the LO caudal. Mid left anterior descending artery best demonstrated in the AP cranial view or the lateral view or RO cranial view. So these are the different view we can assess. Distal LAD better appreciated in RO caudal view or lateral view. LAD diagonal bifurcation in LO caudal view, AP or slightly RO, mainly cranial with slightly RO angulation, or in the patient with the LO cranial. The higher a diagonal, the better appreciated in the LO caudal view. Similarly, proximal circumflex in the RO caudal view, which is better appreciated, followed by the LO caudal view, and the slightly RO and a caudal 30, that is mainly we consider AP caudal view. Distal circumflex, better demonstration in the cranial view. OM bifurcation, AP caudal with slightly RO, and also the LO view will be the better for the circumflex OM bifurcation. RCA proximal in the LO cranial or plain LO view, RCA mid, lateral or the RA view, lateral or the RA view, RCA distal, any cranial angulation or the plain LO will be the better. PDA PLV better appreciated in the cranial view because it is there cranial angulation allowed to separate out the PDA PLV. So these are the different angulation and where the different artery segments we can appreciate the better. Next come what are the segment, what are the artery segment, how we differentiate. So we start with the left main. Left coronary extend from the ostium of the left coronary artery through the bifurcation into left anterior descending and left circumflex artery. So left main start from the origin of ostia till the bifurcation. This is the bifurcation, this is the LAD, this is the circumflex. So it extend up to the bifurcation. So in this caudal view, if you see, there is a left main start from the ear and extend up to the ear till the bifurcation point. This is one of the LA caudal view where the left main bifurcation better appreciate. Now, whenever you want to appreciate the left main ostia, then the cranial angulation, because this is the cuspal margin where the ostia is better appreciate. So if we are doing the intervention of the ostial left main, then the cranial angulation view will be the better. So left main. Next come to the left anterior descending artery. There are the three segments, that is ostial up to the 3 mm, then proximal, mid and distal. Usually the literature says that the first septal, or some literature says the first major diagonal, which from ostia to first major branch is considered the proximal. From distal end of the proximal to the apical segment, we have to take the half segment. So in this between there is a mid LAD segment, the distal is the apical segment. Then first diagonal, that is the branches. The LAD give branches diagonal in lateral territory and septal branches to supply the anterior two-third of the septum. So these are the difference. This is a areocranial view. We can appreciate the mid part of LAD very well. This is the septal branches. Similarly, the epicranial view, we can appreciate the mid and distal part of LAD very well. Similarly, in aleocranial view, the LAD diagonal bifurcation will be appreciated much more better. And areocaudal view, the proximal segment of the LAD much appreciate better in the areocaudal view. So these are the different angulation. The person to person variation and anatomical variation has to be there, but majority time one can appreciate the better. And lateral view demonstrate the LAD, particularly in the mid and distal part very well. So this is the mid and distal part of left anterior descending artery, very well appreciate in the lateral view. Next comes the circumflex. Circumflex origin start from the left main. There is the proximal part up to the first major optis marginal. After that, it is considered a distal. Left dominant, whenever there is a posterior descending artery arise from the circumflex, this is the dominant. When the posterior lateral branches arise from RCA, that is the right dominant. Majority patient will have right dominant circulation. These are the branches. So the proximal circumflex from the origin up to the first optis marginal, from optis marginal to the subsequent part is considered the distal circumflex artery. So caudal view, so we can see this is the caudal view. We can appreciate the circumflex proximal very much well, as well as the ramus or the OM type. So proximal OM, there is a major first OM very much appreciate in the epicaudal view. Similarly, the areocaudal view also show the OM and the PLV branches in the areocaudal view also. So for circumflex, the caudal view is much better option for delineation. If you want to assess the distal OM and all these branches, then cranial view. This is a cranial view, epicranial view, the distal OM women can appreciate better. This is the aleocranial. Whenever the circumflex dominant or co-dominant, then the aleocranial will be the better view to delineate the distal part of circumflex as well as the PLV segment. Alocaudal also the important for the proximal part of circumflex and osteo of the circumflex. The plain aleo also helpful when the dominant, co-dominant and major OM cell. This is a aleo view where so the dominant circumflex. So the whole AV group we can demonstrate the whole AV group. So now come to the right coronary artery. Right coronary artery is the proximal, mid and distal. Proximal from the origin up to the first RV branch, or we can take if we take the arbitrary segment from the acute marginal, so we have to divide acute marginal origin to the origin of the RCA, the mid in equally half. So these are the mid RCA, the proximal RCA, mid RCA and distal RCA up to the crux. These are the segment of the right coronary artery. First branch will be the posterior descending, second is the PLV. In opposite there is the AV nodal artery. Sinus node and cono branch also the branch of the RCA. The LO is the most common view. Usually we hook the RCA in the LO view. This is the proximal part, this is the mid part, this is the proximal part, this is the mid part, and this is the distal part up to the groove. So this is the RCA LO, this is the right coronary artery RO view, the mid part, end phase. We can see the end phase, the mid part of the RCA. Similarly, sometimes the distal PDA-PLV better appreciated in the cranially angulated epicranial, slightly the aleocranial view. This is a PDA-PLV better appreciate. Sometimes the mid RCA we have to tackle in the lateral view. We have better demonstrated in the lateral. This is a lateral imagination of the RCA. So different segment depend on the anatomic variation or where the lesion maximally demonstrated. So the assessment of the coronary artery stenosis is angiography, which is luminography, purely anatomical. Inter and intra-observe very definitely there because it is eyeballing. And oculostenotic reflex, sometimes we overestimate the lesion, there is oculostenotic reflex. So we interpret the angiogram in the severity, calcification, ulceration, thrombus, tortuosity, Any classification we used to apply: reference size, diameter, distal vessel, bifurcation, TIMI, myocardial perfusion, and collateral. We see one by one. Certain terminology: what is the side? Whenever the side branch diameter more than 1.5 is considered significant. Calcification is mild, moderate, and severe. Moderate obvious without cardiac more than severe. Any angiographic epi, even with the stained film, we can appreciate the calcium. Calcify grade and angulation is more than 40. Chronic tocotal occlusion, more than 3 months occlusion or bridging collateral or TIMI zero flow. Filling defect, we will see in the subsequent slide the thrombus. And the lesion angle. Lesion angle also we can see in subsequent slides, so I am skipping that part. So if the angulation is more than 45 is moderate, angulation more than 90 is considered the severe. Side branch size more than 1.5 is a significant side branch. Proximal tortuosity, if band is more than, so before the lesion, if the band is more than 75, lesion distal to the two band more than 75 is moderate, lesion distal to three bands more than 70 is significant. Calcification we will see in the subsequent slide. Filling defect also. Eccentricity, ulceratal intima flare aneurysm. So we can see the length of the lesion is also important. Less than 10 mm lesion length is considered the discrete. Tubular is 10 to 20 mm, and more than 20 mm lesion length is considered the diffuse disease. Ostial is within 3 mm origin considered the ostial. So I am skipping. So there are the certain classification: ACCA, ACCA classification, type A. This is the older classification where they define the simple lesion is type A, discrete, concentric, readily accessible, non-angulated, smooth counter, littoral, not calcification, less than total occlusion, ostial, not ostial in location, no major branch involvement, absence of thrombus. So the lesion success rate by PCI is more than 85%. Similarly, then type B and type C. Type C carry the less success rate, less than 60%. So depending upon the length, eccentricity, angle, calcium, division. Another classification is SKY classification. These are 1 to 4. Lesion SKY 1 do not have type C feature of the ACCHA. So the lowest risk complication. SKY 2, that is a diffuse. Type 3 does not meet criteria of type C lesion but occluded, totally occluded, and but does not meet criteria of type C ACCHA. And type 4 SKY classification is totally occluded and also met the criteria of ACCHA. So these are the type 1, 2, 3, 4 SKY classification. And the success rate, if you see the type 1, the complication rate is 2.4, type 2 SKY complication is 5.1, type 3 type SKY lesion complication 9.8. So the higher the SKY coronary type lesion, then more the complication. And lastly, the Ellis lesion specification. Similarly, there are the variables has been defined for the risk: moderate, strong, correlation. These are the variables that will lead to the more complication to the outcome of the procedure. So SVG is calcification, eccentricity, calcium angle. ACCHA doesn't take account in the venous graph, but SKY lesions, if you see the venous graph, occluded degenerative venous graft are included in the SKY lesion. So post bypass that carry the more complication. Now lesion assessment. Degree of angiographic narrowing reported as the estimated percentage of luminal reduction of most severely narrow segment compared to the adjacent angiographically normal vessel segment seen in the worst X-ray projection. Exact evaluation impossible, 20 plus or minus 20 variability will be there. We consider the significant lesion if the lesion the diameter more than 50% narrow, area more than 70% narrow. Very long lesion, even if the less than 50%, may become significant physiologically. Visual assessment method tend to underestimate the mild lesion and overestimate the significant lesion. Humans are basically biased individuals, similar to the EF estimate. Just we assess the EF by the echo. Similarly, we assess the lesion by the angiography visual. Cannot use by study of borderline lesion. But it is the easiest, quickest, and lots of lack of error. So whenever there is a mild lesion, this less than 50% diameter stenosis, moderate stenosis is 75. The lumen diameter reduction from 51 up to, but not exceeding the 75%. And severe lesion is a 75% to 95% diameter lesion. The lumen diameter reduction from 76 up to but not exceeding 95. 99 only the string sign will be present, 100% occluded, though no anterior dye, craftable. These are the terminology we use for the reporting. The segment visualized and appears to be healthy for the graft attachment. Absent. Absent segment means indicate the segment is absent due to unquestionable anatomical variation. Vessel may be absent due to proximal occluder or anomalous origin. Gives collateral means that segment give collateral to the other respective branch. And small, the vessels or segment is small throughout course anatomical variation or due to diffuse stenosis. Lesion length usually measured between the shoulder to shoulder. If be more than 20 mm is considered the diffuse. The tandem stenosis, if the gap between the two lesions less than 3 reference diameter of vessel, means the vessel reference diameter is 3 mm. So up to the within the 9 mm it should be, so it is considered tandem. More than 9 it is considered the sequential. So the lesion alignment in this way. So these two lesions are the tandem, but this lesion is a sequential, far distance. So this is a sequential. Here also we cannot take the other vessel lesion for the consideration of tandem or sequential, but this circumflex parent having the two lesions, one is a focal, one is a tubular, both appear to be sequential because more than 3 mm diameter of reference vessel. Arterial calcification, light heavy weight. So if you see so in this, even without running the steel frame, we can appreciate the calcium. So it is a heavy calcium. So heavy calcification of artery. Here is also the heavy calcification, but it is the intralesional as well as pre and post. So lesion calcification before the stenosis and at the site of stenosis also important. Length less than 10 mm is considered discrete, and more than 10 mm is considered 10 to 20 is tubular. This is the discrete lesion, where the focal, where this one is the long lesion. There we consider more than 20 mm. If you start from year to year, then this is considered can fall in category of tubular. Eccentricity into orthogonal view, lesion appears same, that more of you angiographically concentric. In one view it is appears significant, other view it is non-significant, it considers the eccentric. The definition is lumen axis located along the long axis of the artery on either side, but by no more than 20% of normal arterial diameter. Ostial lesion, that is within 3 mm of origin. So this is ostial lesion, within circumference, this is ostial lesion, within 3 mm of origin. Ostial lesion is aortostial, that is left main ostia, or the bifurcation ostial. This is the bifurcation ostial. So ostial lesion defined as those arising within 3 mm of origin of vessel or branch. Two types, either aortostial or the non-aortostial. Aortostial lesion are the fibrocalcific, require the atherectomy, the special modification technique required, and angulation measured at a site of maximum angulation measured at a site of lesion. Side branch we have taken already discussed 1.5 mm diameter. The lesion counter either smooth, suggests fibrotic, irregular, either thrombus, ulcerated ACS and thrombus. So thrombus is the intraluminal filling defect round, visible in tube, largely separated from the vessel wall, and documentation or embolization. So if you see this angiography, so this is a filling defect. So we can appreciate the filling defect separated from the vessel wall. This is a filling defect. It may be the dissection, it may be the thrombus, but this patient given this is a thrombus by giving the GP2B for the after this. So most probably it was filling defect. One can confirm by the imaging, either OCT or the IVAS, but this patient had the thrombus. Angulation, the moderate angulation is 40 to 90, severe is more than 90. So if you want to assess this lesion, so hairpin angulation is a severe bend before this circumflex lesion. So patient having hairpin severe angulation, so severe tortuosity before the assessing the lesion. Sometimes angulation at the site of lesion also carries the adverse prognosis. Aneurysm is a focal segment. It is 1.5 times from the reference diameter. If focal. So this is this patient having the dilatation of vessel, but is a focal less than 1/3 of whole LAD length. If when we consider ectasia is a focal dilatation extending more than 1/3 of the artery segment. So this is a whole circumflex. If it is a 50% of circumflex dilated, so it is considered ectasia. So the difference between ectasia and the aneurysm is the length of the, whether is dilated part is more than 1/3 of the reference vessel, then this is ectasia. So this is ectasia of LAD and the circumflex. Bifurcation, this bifurcation classic Medina is most commonly, this is main vessel, distal vessel and bibrand. This is main vessel is a 1 0 0, this is a 0 1 0, 0, this is a 1 1 0. So according to Medina 1 1 1, this is the Medina 1 1 1. So these are the bifurcation classification widely accepted and easy to remember. So this patient is example of the bifurcation. This patient is distal, the main vessel disease, sideburn disease and the main vessel disease. So proximal main vessel, distal main vessel and the side, the Medina 1 1 1. This is the classification of the bifurcation. TIMI flow grade. Absence of any antigraph is 0. Faint penetration 1. Partial penetration without complete opacification. But sluggish complete obliquity, that is TIMI 2, and complete normal obliquity, TIMI 3. So this patient is TIMI 0 1 flow because hardly penetration without filling of the both border 0 to 1 flow. These are the example of the TIMI 0 to 1 flow. Myocardial perfusion, either minimal or no, dye slowly appear but delay more than take 30 seconds to disappear. Entry and exit, the myocardial blush is there but disappearance blush requires more than 3 cardiac cycles and grade 3 blush is the normal. So this patient is particularly used in the acute ACS PAMI. So if you see the myocardial blush, so myocardial blush has been started. So here the myocardial blush has been started. It takes more than 3 cardiac cycles, 1, 2, 3, 4, 5, 6. Till after the 6th cardiac cycle it is persisted. So it is myocardial grade 2. Okay. So now is a TIMI frame count to consider the slope of normal TIMI frame count is a 24 plus or minus 10. LAD is the longer vessel. So whatever the TIMI frame count we obtain in the LAD, that divided by 1.7 we obtain the corrected TIMI frame count. It will corrected TIMI frame count and LCX RCA TIMI frame count around 24 plus or minus 7 plus or minus 10. So we start the TIMI frame count, just visualizing both border until reaches up to the apex for the LAD, the distal most portion of the OM. So distal most portion of OM here or lower branch. For LAD, it has to reaches up to the apex. So calculating the frame and we can obtain. So in this case, frame required to reaches up to the distal OM. The frame die number of frame required to reaches the die up to the apex. It is the TIMI frame count for the left coronary artery. For right coronary artery, usually we take the crux at the end point. So start from here to reaches the die up to the TIMI frame count reaches up to the here. This is AV nodal branch. This is the TIMI frame count. So number of frame required to die reaches from the ostia to this AV nodal branch for calculating the RCA. The normal TIMI frame count is 24 plus or minus 10. And now it is the J score. Just for the CTO, there are the whether is a blunt, taper, or whether is a blunt, then side branch is there, and calcification in the CTO segment, bend, and the occlusal length is more than 20, and reattempt. So I will show you this. So if this is a CTO, mid LAD CTO, there is a slightly tapered segment. So we can taper, there is a 0. Now this giving the collateral, the lesion length. The lesion length appears. This is this same in contralateral. So approximately the 20 millimeter lesion length or more. some we can appreciate the calcium. So some calcium is there. So the patient is more than 20 millimeter tapered. So once again, how will denote? So that is a tapered 0, calcium present 1, bridging collateral we cannot appreciate bridging collateral absent 0, ocular lesion length more than 21. So the JCTO score is 2. This is the first time that this patient JCTO score is 2. And collateral supply, this is a collateral absent, 1 is the absent collateral supply, 2 is the minimal, and 3 is the well. So this patient will have good collateral, 3 meter mature collateral, that is totally opacifying the donor vessel. So this vessel patient having the good collateral. Now lastly the SYNTAX score that we can helpful to objectively patient will subject for the PTCA versus bypass as per the Texas stand using, particularly right dominance 1, 2, 3, 4, left dominance, the PDAPL arise one. What are the so RCA proximal, mid and distal carrying the 1 point, posterior descending artery carries the 1 point, PLV branches carries the 0.5 point, left main 5, proximal LAD 2.5, mid LAD 2.5, 3.5, 2.1. So similarly each segment giving the weightage. So if there is a lesion, flowing lesion tight, if it is left main 5 into 2, if left main totally occluded, then 5 multiplied by 5, that is 25. So each segment giving the score multiplied by lesion either 2 or 5. And other character, total occlusion 1, blunt stem 1, bridging collateral 1. So add on point, from that the SYNTAX score has been derived. These are the separate segments. So aortosteal carries the 1 point, tortuosity carries the 1, heavy calcium carries the 1 point, lesion length more than 20 carries the 1, thrombus carrying the 1 point, diffuse disease carries the 1 point. So these are the variables taken into account for the SYNTAX: dominant, number of lesions, segment involved, total occlusion, trifurcation, bifurcation, aortosteal, tortuosity, length, heavy calcium, thrombus and diffuse disease. From that we are taking the calculate the SYNTAX score. So from higher the SYNTAX score, the CBG will be better, lower the SYNTAX score, the PTC will be the better. Now finally the limitation of the angiography. If patient is obese, then the quality of the angiography will not good. Vasomotor stone, vessel motor is too much tachycardia, then the interpretation not good. Cyclical variation in diameter, end diastole, systole, sometimes variation we may feel. Geometry consider vessel curvature. Sometimes some projection may be required for the vessel projection. X-ray related, methodology related. So there are the different drawback of the standard angiography. Overlapping segment, foreshortening. We overestimate the lesion in the foreshortened segment. So we have to assess the lesion in the longest possible manner. If the quality of dye injection is streaming, then the overestimate the lesion. So inadequate number, the mistake inadequate number of projection, inadequate injection contrast material, superciliative, catheter-induced spasm, variation, myocardial breach, total occlusion, wire-induced spasm. These are the variable factor influence the assessment of the lesion by angiography. Diffuse lesion, we underestimate the lesion. Eccentric lesion, we underestimate the lesion. So these are the pitfall of the angiography. So inadequate vessel application, guide not properly engaged, streaming effect, eccentric and calcific lesion, inaccurate assessment by the angiography, superimposition of side branch will lead to the underestimate the lesion, microchannel recanal difficult differentiate CTO as well as bridging collateral. Thank you very much.